Good afternoon, everybody. Welcome to this afternoon session of Pursue General Pathology. Today we have 5L and we are streaming live from Kolkata. And today the topic is hemodynamic disorder, edema, embolism, infarction, and shock. This is session 2. Last time Dr. Palash Kumar Mandal had taken thromboembolism and a bit of various other activities. Today he will continue from where he left last time. So I welcome Dr. Major Palash Kumar Mandal, who is an associate professor of pathology in Sagore Dutta Medical College, Kolkata, a lab director in Desun Hospital and Heart Institute, Kolkata. Thank you, sir, for joining. And before we start, let me request everyone, please keep your mic muted, please keep your camera off, and please don't share your screen. With this, let me ask Dr. Major Palash Mandal, sir, please take over and share your screen. Thank you so much, sir.
Thank you, sir.
Yeah, I can see your screen. Please make it full screen, please. Yeah, wonderful.
Good afternoon, everybody. So this will be the second lecture on hemodynamic disorders. Since we had started with thromboembolism, infarction, so I thought to continue it, I should start with the bleeding and coagulation disorders instead of edema and shock. So our third and final lecture of this topic will be edema and shock, and today we will be discussing about the bleeding disorders and the coagulation disorders. There is always a hitch in the beginning.
No
I apologize
problem.
for that.
You can restart everything. No issues.
So I think it will start like every time it happens like this only.
Your screen is not changing, is it?
Yes. Now.
Yeah, that's fine. Now it's fine. Right.
So we will be discussing our topic under the following headings: hemostasis, disorders due to abnormality of the blood vessels, thrombocytopenia, immune thrombocytopenia, acute and chronic, lab diagnosis and treatment of it, coagulation disorders. It's a big topic, I know, but since the holidays are coming and I have to finish the whole thing in this coming 2 weeks, so I thought I will squeeze two topics into one. Let's see how far we progress. I won't, of course, rush, but I have put these two topics together. So coagulation disorders, and we will be discussing mostly on hemophilia and von Willebrand, and finally the difference between bleeding disorders and coagulation disorders. There is spelling mistake of bleeding disorders here.
So you take your time and go slowly. Even if we cross 1 hour duration, no issues.
Right.
Yeah, thanks.
So to begin with, hemostasis. This term we have already heard several times during the course of our previous lectures. So basic thing is that the mechanism by which bleeding from an injured vessel is arrested by formation of a thrombus is known as hemostasis. So a thrombus is as good as a clot, but clot and thrombus, they have some differences. Clot can be external clot also, I mean outside the body also, but a thrombus has to be within the body. Okay, functions, we have discussed the functions of hemostasis. The components we know because we have discussed all these things in our previous lectures. Now we know this also, that there is a primary hemostasis which is mediated mostly by the platelet along with the interaction with vascular endothelial cells, occurs within seconds of injury, whereas the secondary or the permanent hemostasis is due to the activation of the coagulation factors and may take several minutes. Initial stage or the stage of primary hemostasis is the formation of platelet plug, whereas the stage of secondary hemostasis is the formation of stable fibrin plug, and both have similar functions because the main aim is to control the bleeding. Now coming to the bleeding disorders, you see there are two terms. They may look similar, but they are slightly different. One is the bleeding disorders, which relate mostly to the abnormalities of the blood vessels as well as the platelet disorders. And second is the coagulation disorders, which is basically due to the deficiency of coagulation factors. Okay, so first we start with the bleeding disorders. So bleeding disorders due to the abnormality of blood vessels can be acquired or inherited. So under the acquired heading, we have this anaphylactoid purpura, also known as henoxalan purpura. There can be abnormalities of the blood vessels can happen due to infections, especially the gram-negative infections, scurvy, senile purpura, purpura simplex, mechanical purpura, drugs like corticosteroids, there is a spelling mistake here also, and Cushing syndrome. The inherited ones, which are rather a little uncommon: hereditary hemorrhagic telangiectasia, hereditary connective tissue disorders like Ehlers-Danlos, Marfan, osteogenesis imperfecta, and so on. So these are the basic bleeding disorders caused due to acquired as well as inherited conditions. And here under this heading, the acquired conditions predominate. Okay. Now coming to thrombocytopenia. Thrombocytopenia by definition means decreased number of platelets below the normal level. We know the normal level of platelets is 1.5 to 4 lakhs per cubic millimeter or per microliter. So that is the normal range of platelets. We call it as a biological reference interval, and that below that range, something the whenever the platelet levels go below that range, we call it thrombocytopenia. So there are basic mechanisms leading to thrombocytopenia, four. One is the increased destruction of platelets. Second is the decreased production of platelets. Second is dilutional thrombocytopenia. And last one is the increased sequestration. That also in a way is destruction of the platelets. So basically these two things mostly are the more important ones among these four. One is the increased destruction and the second one is this decreased production. Okay. Now coming to the practical issue, if a person has a lower range of platelets between say 50,000 up to 1,50,000, that is 1,49,000, let us say, so there is actually no problem. The problem starts when the platelet levels fall below that level, that is below 50,000. So clinically, if it is between one bit less than 1,50,000 up to 50,000, so there is actually no clinical problem is detected externally. Okay, even internally there is no problem, it is fine. Now between 20,000 to 50,000, only bleeding happens when there is a trauma or mild surgery. Below 20,000, that is the critical level, so even spontaneous hemorrhage can start. But as we see, body tries to acclimatize, so even if it is falling below 20,000, at times we do not see spontaneous hemorrhage if the duration of thrombocytopenia is of a longer duration. So body tries to acclimatize itself, and even if it is falling below 20,000, but the clinician and the pathologist boats should be alert if the level of platelet actually falls between below 20,000. Okay. Now coming to causes of thrombocytopenia. So you see, thrombocytopenia means reduction in the number of platelets, and you have to, we have already discussed the important causes, and we will divide these important causes and find out what are those things which are leading to those important causes. Okay, so first is the increased destruction of platelets. One is immunologically mediated, one is non-immunologically mediated. Under the immunologically mediated category, the commonest one is the immune thrombocytopenic purpura. Initially, or in the past, it was known as idiopathic thrombocytopenic purpura because the actual cause is unknown. But now it has been confirmed that it is due to some immune mechanism. So the name has changed. The ITP, ITP remains the same. The name has been slightly changed to immune thrombocytopenic purpura. It can be of acute type, it can be of chronic type. We will discuss it in details because it comes as a problem based questions in the MBBS. So in the second prof exam, at times you may get a problem based question on ITP, that is immune thrombocytopenic purpura. So and you have to establish the cause. You have to go into the lab diagnosis and give a bit about the treatment also. Next, immunologically mediated cause can be SLE, systemic lupus erythematosus, which is a collagen vascular disorders, and B type of non-Hodgkin lymphoma. So B cell non-Hodgkin lymphoma, usually the DLBCL category. There are drugs which also lead to immune destruction. Most of them is a quinine, which is used in malaria resistant cases of malaria. We still use quinine, please remember. There are some other drugs like penicillin, gold salts, heparin, quinidine, etc. There are infections like dengue, malaria, HIV, hepatitis C, and even certain cases of post-transfusion purpura can be due to immunologically mediated destruction of the platelets. There are some non-immune causes as well. One of them is DIC, disseminated intravascular coagulation. I had told you that this topic needs a separate lecture, so we will do that sometime later. Disseminated intravascular coagulation, and there are two other categories like thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. These are the non-immune causes of platelet destruction. Decreased production of platelets, the second category. Hereditary category and acquired category. The hereditary category are always uncommon, whereas the acquired categories are common under this heading. So under the hereditary category, we have Fanconi's anemia and Wiskott-Aldrich syndrome. Under the acquired category, we have aplastic anemia, bone marrow infiltration due to leukemia, non-Hodgkin lymphoma, or a metastatic carcinoma. We have megaloblastic anemia. We have drug-related thrombocytopenia due to decreased production, not due to increased destruction. There were drugs which were causing increased destruction like quinine, quinidine, etc. But there are also drugs which decrease the production of platelets. Most important of them is the cytotoxic drugs. Okay, cytotoxic drugs which are used for the treatment of malignant disorders. In short, they are known as the chemotherapeutic drugs. So they cause uh, the decreased production of platelets. Okay, so the others are alcohol, radiation. Radiation is also related to treatment of malignancy. So these are the drugs. Second is the dilutional thrombocytopenia, very rare thing. Okay, so whenever blood transfusion is given, it is given in a measured quantity. So keeping in pace with the body's blood volume, the body weight, everything, the blood transfusion is given. As you know, these days, in the days of component separation, and we are more used to giving components rather than whole blood transfusion, because whole blood transfusion has its own demerits. So we stick to component transfusion, and whenever there is a need of RBCs to raise the hemoglobin content, so we give packed cell volume. Okay, packed cell, not packed cell volume, packed RBCs. So packed RBCs are given, but in some cases, suppose in the peripheral centers and small towns where component separation is not prevalent, so still whole blood transfusion is given. There, if a person is suffering from massive suffering from anemia due to, say, hemorrhage, blood loss, like that, so that in those conditions, so blood is given. There may be 6-7 bottles of whole blood may be given at a time. So those conditions may lead to this dilutional thrombocytopenia. Okay, so massive blood transfusion, actually there is a definition of massive blood transfusion: more than 50% of the blood volume, if it is transfused, that is called massive blood transfusion. So we have roughly uh, 5 liters of blood in our 4.5 to 5 liters of blood in our system. So if it is more than 50% at one go, it is called massive blood transfusion. Now, increased sequestration. Sequestration is also indirect way of increased destruction. Okay, but this is a normal physiological phenomenon which happens in spleen. So physiologically, all the cells of our blood cells are destroyed in the spleen and recycled. Some of them are flushed out of the system, some of the products are recycled. Like if RBCs are destroyed, the iron is recycled and is taken up by the new RBCs. Okay, so this process goes on. So this process of the process of the destruction of the cells after their senescence, that is, once the cells have come to their end by the age, so that time there the spleen, which is also known as the graveyard of the blood cells, so that takes over the function of destroying these cells. Okay, so here if the spleen becomes overactive, if it destroys more cells than necessary, then it is called increased sequestration, and the condition where this can happen is hypersplenism. The spleen becomes enlarged, the spleen becomes a voracious eater. Okay, instead of eating a few particles, it starts eating more and more. So that case, there is a condition generated which is known as pancytopenia, and pancytopenia leads to thrombocytopenia. All the cells, not only the platelets, all the blood cells, RBCs, WBCs, platelets, all are increasingly destroyed by the hypersplenism condition. Okay. Bleeding disorders due to defective platelet function. So, defective platelet function, we were till this time we were concentrating on the numbers. Okay, this was the numbers, destruction, production, that all dealt with the numbers. Now we are dealing with the function. There is a difference. So here we are coming to the defective platelet function. The numbers may be normal. A person may be having, suppose, 1,20,000 count, even 1,50,000 count, but the person is suffering from bleeding disorder. That may be due to some inherited or acquired defect in platelet function. One of the commonest inherited cause of platelet dysfunction is the Bernard-Soulier syndrome. It leads to defects of adhesion of the platelet to the endothelium. You see, the basic thing in primary platelet plug formation is the adherence of the platelet to the endothelial wall, which is also needs another factor, that is von Willebrand factor. And von Willebrand factor and platelets, they are joined together by some other factors. One of them is GP1B, 1B9, GP2B3A. So these are the factors which are responsible for the various functions of platelet. One is the addition function, one is the aggregation function. Okay, aggregation means coming together. So if more number of platelets come together, the initial clot will be more stable. Okay, if the platelet, they come together but are failing to adhere to the endothelial cell or the blood vessel endothelial wall, so that leads to the defect of adhesion. So defect or deficiency in the GP1B9 and the deficiency of GP2B3A leads to these inherited problems. And there is also defect in secretion and storage pool disorders, and there are various names. Okay, I have not gone into the details of those names, you can find it in your book. So basic idea, the aim of this lecture is to give you the basic idea from which you can start and you can go ahead with it. There is no end of knowledge. You see, you can have n number of books, the internet is full of knowledge, but you our aim as facilitators of learning, we don't call ourselves as teachers anymore, so we are the facilitators of learning. So we try to facilitate your education, whether be it an undergraduate education or a postgraduate education, by facilitating or helping you to start your reading. Okay, so that is our main function these days. Acquired causes may be mostly due to two conditions. One is the drug related conditions. One of them is aspirin, the NSAIDs, which lead to defect in aggregation and release of what? Release of the enzymes from the platelets. They release a lot of this cytokines. Okay, those cytokines, if they are not released properly, they will again lead to functional defects. Uremia. Uremia is a condition where the blood urea creatinine levels are increased in the blood, which lead to a lot of problems, and that uremia can also lead to defect in the adhesion and aggregation and also release of the platelet enzymes. ITP, idiopathic or immune thrombocytopenic purpura. Okay, so this thing you have to read a little in depth, because as I told you, there are problem based questions related to ITP. So types, first is the newly diagnosed types known as the acute ITP, which is diagnosed in the first which is the first 3 months after the diagnosis. They are called acute ITP. If it is between 3 to 12 months, it is known as persistent ITP. If it is more than 12 months, that is more than a year, the ITP is persisting, it becomes a chronic ITP. The names acute and chronic, I have already told you. Acute means of a shorter duration and chronic means of a longer duration. Okay. Symptoms and manifestations may vary. Mild asymptomatic thrombocytopenia to severe thrombocytopenia and bleeding may happen. Okay, so these immune mechanisms, they have effect, uh, different types of effect in different persons depending on the immune status of the individual. Okay, so one person may have one series of manifestation, whereas another person may have more severe or less severe manifestation, so that may vary. Now coming to acute immune thrombocytopenic purpura, the clinical manifestations usually start following a viral infection or a vaccination. Usually the patient is a child, 2 to 6-year-old children, and the male-female ratio is almost same. It is of a sudden duration, sudden onset, because I told you acute means sudden onset and shorter duration, and happens mostly during winters or spring. And how does it manifest as? It manifests as cutaneous or mucus bleeding. Okay, mucous membrane bleeding, that is inside the oral cavity, inside the nasal bleeding may happen. Cutaneous means over the skin surface. So skin surface bleeding may lead to these terms, things: purpura, ecchymosis. Purpura is the smaller dot-like bleeding points just beneath the skin is purpura. Ecchymosis is when the purpuric spots, they coalesce together, a larger surface of bleeding appears under the skin, that is known as ecchymosis. Okay, purpura are the small bleeding spots like dots. Okay, like spray painting. If you think of a spray painting, then you can understand purpura better. Ecchymosis is a blotch. Okay, when some color falls on a this canvas, it produces a blotch, that is ecchymosis. Epistaxis means bleeding from the nose. Gum bleeding is there. Hematuria means bleeding from the bleeding with urine. Okay, so these are the terms and these are the manifestations which happen with ITP. Okay, please, you have to understand these terms properly, because in medicine you have to be acquainted with these medical terminologies, because you cannot the layman may use certain other terms, but whenever you are writing your answers, whenever you are answering your questions to an examiner, or you are writing a prescription, it is better always to use the medical terminologies. Okay, now the disease can be self-limited. That is the good part about acute ITP. It is usually self-limited and remission occurs between 2 to 6 weeks. 6 weeks is 1.5 months. Okay, so we told you that acute ITP has a shorter duration, that is less than 3 months duration, and the disease is self-limited, and in however in 20% of the children the disease may persist beyond 6 months and may go towards chronicity, Okay, what is the pathogenesis? The immune complexes of the viral antigens and the antiviral antibodies to FC receptors on platelets, they combine together. The viral antigens and the antibodies to the viral antigens, they combine and form immune complexes, and they bind to the receptors of the on the platelets, that is the FC receptors of the platelets, and eventually lead to immune destruction of the platelets. Whenever we will discuss the immunology, in fact after hemodynamic disorders we will discuss immunology only, so that time we will discuss. There are 4 types of hypersensitivity reaction: type 1, type 2, type 3 and type 4. So under one of these categories, this type 2, this immune destruction comes. Okay, so immune destruction of the platelets and eventually the engulfment by the macrophages in the spleen. So spleen, as we have told you, is the graveyard of all the cells in our body, mostly the this hemopoietic cells, not all cells, hemopoietic cells, and even that the function is done by the macrophages which reside in the spleen in large numbers. Okay, chronic ITP. Chronic ITP, slow start. Okay, now in acute there is a sudden onset, but here it's just indolent disease, slow start with remissions and recurrences over the years. At one point of time you may not see any disease, at one point of time you may see the exuberance of the disease. So a common term which is used: now you see me, now you don't. Okay, so that is the crux of chronic ITP. Happens in young adults, and females are more affected than the males. In acute ITP, the sex distribution was same. That is, males is to female ratio was almost same. However, in chronic ITP, females are much more affected than the males. This also presents as similar mucocutaneous bleeding, menorrhagia, because mostly it happens in young adults. There may be chronic bleeding, and chronic bleeding leads to anemia, and though some may be asymptomatic, because the chronicity of any infection, the body, whenever a disease becomes chronic, the body by its own mechanism tries to acclimatize itself, tries to accommodate itself, and spleen is not palpable in chronic ITP. Okay, in any ITP, spleen is not palpable. Remember that, because hypersplenism is a different condition. Hypersplenism is a condition which can lead to platelet destruction by increased sequestration. But here we are dealing with de decreased, increased production, increased destruction of platelets. Okay, so pathogenesis here also is slightly different, but immune mediated. Both are immune mediated. Okay, so here autoantibodies predominantly of the IgG class are directed against the complexes, that is GP2A and 3B, 2B and 3A, and 1B and 9, which lead to destruction of the platelets and induce platelet dysfunction. These molecules, this GP2B, 3A, these molecules are basically present near the von Willebrand factor, and they are present in the platelet, not in near the von Willebrand factor. They are present in the platelet. They help in the adhesion of the platelets with the von Willebrand factor. Okay, so that is very important, because you see, you have to understand why this is important, why this we are talking of this GP's glycoprotein, GP2B, 3A, and GP1B9. They are related to the functional activity of the platelet. Okay, and once the antibodies are directed against those antigens which are present in the platelet, they lead to platelet destruction and also lead to platelet dysfunction. If the platelet is dysfunctional, it is as good as non-functional. Okay, so antibodies coated with the platelets are recognized by the F3 receptors on the macrophages and eventually destroyed. The destruction part is almost similar, but the difference is the immune complexes of the viral antigens. Okay, the immune complexes, the viral antigens are present, and the antigen antibody complex associated with viral antigens, they destroy the platelet. They sit on the platelets and destroy. There the antigens are, or the antibodies are not directed towards any platelet antigen. This is the difference. You see, that's why I have gone back to the previous slide, that here there the antibodies are not directed to any of the antigens of platelets. What is happening here? There are some viral antigens which are floating inside the blood. The antigens are present inside the blood, and the body has produced some antibodies against those viral antigens, because we saw that there is these usually happen after some viral infection or vaccination. Vaccination is also, we give low dose viral antigens. Okay, so the complex is forming within the blood, in the plasma. The immune complex is forming inside the flowing blood, that is the plasma, and the complex goes and sits on the platelets, because there are receptors of platelets which will draw that complex to itself. Am I clear? The complex of antigen, that is viral antigen and viral antibody, that comes as a ball and attacks the platelets and leads to the immune destruction. Whereas in chronic ITP, the antibodies are directed against the platelets own antigens, that is GP2B or 3A or GP1B and 9. So this is known as autoimmunity. Okay, that was also kind of an autoimmunity, but here the antibodies are directly attacking platelet antigen. I think you have followed the difference between these two. Now the antibody coated platelets are recognized by Fc receptors, and last part is same, that is the destruction by macrophages within the spleen. And here in chronic ITP, in some cases, the antibodies may be directed against the megakaryocytes, which are the mothers of platelets. Okay, so antibodies may be directed towards the megakaryocytes also, which are residing in the bone marrow. The findings, the laboratory findings are very important, you see, because to diagnose any case you have to go with the laboratory findings. So whenever a lab diagnosis comes or whenever you have to diagnose a particular case, I always tell my students, start with the clinical features. Before that you can before that also you have to start with the history, the person's manifestation, how it started. Is it of a shorter duration? Is it of a longer duration? What are the clinical signs and symptoms? How the patient will tell, I am having this, I am having giddiness, I am having these bleeding spots, I am having bleeding from the nose. Those are the patient's signs, symptoms. What are the signs? Signs are elicited by the doctor who is examining the patient. Okay, anemia is a sign, and there are many other signs as well. So these things are signs. Signs and symptoms are different. Okay, I think you have a basic understandings of these two terminologies. Signs are the ones which are elicited by the doctor while examining the patient, whereas symptoms are the features which are experienced by the patient, and the patient tells that I am a doctor, I am having this thing. Okay, so this is the difference between symptoms of patients and signs examined by the doctor. So laboratory findings, before the laboratory findings, we have to take the patient detailed history. So these days the doctors are very busy seeing n number of patients, whether be it a government hospital, whether be it a private clinic. So the doctors pay less heed to the clinical history, which is very, very important, I tell you. So then comes the signs and symptoms, then comes the signs, then comes the lab investigations. And whenever we discuss the lab investigations, do remember, don't think of only the pathology lab investigations. It can be radiological investigations also, and radiological investigations form a very important part of the diagnostic armamentarium these days. Okay, so though in this bleeding disorders, mostly we will restrict our talk to this pathological laboratory investigations. However, in certain conditions we will definitely include radiological investigations as well. So coming to the first and foremost important investigation is the blood examination, because we are suspecting it to be a bleeding disorder because of the nature of the symptoms. Okay, the signs and symptoms have given a clue to us that it could be a bleeding disorder. So you see, whenever you examine a patient, keep your eyes, ears, everything open, and you have to have an active mind to understand what is the problem. You cannot take a long time to think what is the problem. So if the problem is evident, you have to be very quick. That's how you can come to a quick diagnosis. and initially the diagnosis may be just a differential diagnosis. You may not be able to reach to a final diagnosis without investigations, but you have to come to a differential diagnosis. That means that is a rough diagnosis, and there can be some differentials, means there can be some other possibilities also. Understand? So that is called differential diagnosis. Coming to first thing is the anemia. Presence of anemia is seen by the lowering of the hemoglobin content and the RBC count. So that is seen definitely because of the persistent bleeding activity. Then the platelets, whenever we see the peripheral blood or we see the blood count, the total count of platelets will be reduced, because that is the key finding. We are dealing with a case of ITP, whether be it acute or chronic. The key finding, it is the decreased platelet count. In acute, it is markedly reduced. It is less than 20,000 at times, which is a cause of spontaneous bleeding. And in chronic cases, as I have told you, body tries to acclimatize itself. The count may be variable. It is usually around 50,000 per cubic millimeter, not cm. It is actually cubic millimeter or per microliter. These days the microliter is preferred over cubic millimeter. Okay, so this is not cm, cmm. And bleeding may be mild because there may be some giant or hyperreactive platelets, though the count may be low, but the platelets may be the newly formed platelets may be larger in size, and they may be hyperactive. They may actually compensate for the number by their action. Okay. In peripherals, the peripheral smear examination is very important to rule out true thrombocytopenia from something known as pseudo thrombocytopenia. We, the laboratory practitioners, we, the lab medicine practitioners, we always face this problem, because the cell counters, the machine which counts the cells, that is the number of RBCs, WBCs, and platelets. We have semi-automated cell counters. We have fully automated cell counters, but many of them, they have this problem of counting the platelet, because most of these counters, they use the size and also the number of granularity of the cytoplasm to give a value. Okay, so if the size is increased, as the name says, giant platelets, the size becomes large, so it may miscalculate and think it to be a, suppose, a lymphocyte or a RBC. If the size becomes very small, it may think it to be a dust particles, because there are, these limits are set. The limits are set by the manufacturer. The limits are set that if the size becomes more than this, it is not under this category, it is something else. So that leads to a condition known as pseudo thrombocytopenia, means that though the thrombocyte or the platelet levels are normal, but the machine or the cell counter is giving a false impression of thrombocytopenia. Okay, so peripheral blood examination, that is the visual blood examination after staining the peripheral blood smear, that is very important. Whether a technician is seeing or a pathologist is seeing, but the peripheral blood examination is very important. Then comes aplastic anemia, which is one of the important causes of anemia. So you have to rule out whether only the platelet component is low, or there is pancytopenia. Pancytopenia means there are all the component, that is, there is anemia, there is that is the WBCs are also less, that is called leukopenia, and also thrombocytopenia. Whenever the three components are reduced together, the chances, that is called pancytopenia, and the chances may be that it is a case of aplastic anemia. Okay, that is, there is the bone marrow failure. That may be due to various causes. Aplastic anemia is a chapter by itself, so I am not going to the details. There can be leukemia, that is the malignancy of the blood cells. The malignancy of the blood cells, that is the leukemia, can also lead to reduced, primarily acute leukemia leads to thrombocytopenia. So you have to see the peripheral blood, you have to see the total count of the WBCs to rule out a leukemic process. There can be megaloblastic anemia also due to vitamin B12 and folic acid deficiency. That also leads to thrombocytopenia. And there can be a pre-leukemic condition known as myelodysplastic syndrome. So that can also lead to thrombocytopenia. Now, examination of the bone marrow. So that was the examination of the peripheral blood and the whole blood, and then comes the peripheral examination of the bone marrow. So bone marrow examination is a special procedure. Bone marrow has to be taken out from the from some areas. We know that posterior superior iliac spine in adults, also the sternum, which is rarely done. The sternum is one of the sites. The posterior superior iliac spine is a common site, and also in children we can take the bone marrow from the tibia. So these are the various sites from where we can collect the bone marrow. Okay. So after collection of the bone marrow, we make smears on the slides and examine after staining with the normal Leishman stain. The Leishman stain which is used to stain the normal peripheral blood is the same stain which is used to stain the bone marrow smears also, but the time taken for the smear staining is much more. Okay. So what do we see here? We see the megakaryocytes are increased or normal in number. Though the total platelets in the blood, peripheral blood, are reduced, but the megakaryocytes appear almost normal or maybe even increased. So that is an indication that there is some destruction in the platelets. So that is immune destruction. Okay. So we are dealing with ITP, immunologically mediated thrombocytopenia. Okay. So here the platelets are reduced, but the megakaryocytes, their mothers, the megakaryocytes, they are normal or even increased, because they have to produce more platelets because the platelets are gradually being destroyed. And the megakaryocytes may be hypogranular, hypolobated, because the immature megakaryocytes are usually hypolobated. The more mature megakaryocytes have more lobes, the less mature megakaryocytes have less lobes. They may be even vacuolated, and there may be lack of budding. Buddings is actually an indicator of platelet production. So if the megakaryocytes are nascent or young, so they may have these features of hypogranularity, hypolobations, etc. Coagulation profile. We are dealing with the laboratory findings in case of ITP. So next we will see the coagulation profile. Actually, before the bone marrow examination, I would place coagulation profile before the bone marrow examination. Okay, but it is fine if you can write bone marrow also before that. So coagulation profile, what do we see? We see the bleeding time is increased, whereas the coagulation time, the others normal means the coagulation time, and these days the coagulation time is not done. The more important tests which are done to see the coagulation time are the prothrombin time and partial activated partial thromboplastin time, APTT. So P time and the APTT, prothrombin time, and the activated partial thromboplastin time, they are normal. Okay. Whereas the bleeding time which is done, I am not going to details how it is done. So normal bleeding time is by this particular IV's method is 2 to 7 minutes, and if it is increased, it may indicate or it indicates that there is some deficiency of either platelet or blood vessel. It may indicate both. Okay. and there is deficient clot retraction. It is also one of the indicator. The deficient clot retraction may be due to thrombocytopenia. Platelet antibodies are, if they are detected, they may be found, and they may be, the concentration may be more, but that is rather non-specific. Because why this is non-specific? Because in acute ITP, you see, we have antiviral antibodies, not antiplatelet antibodies. Okay, so the antiviral antibodies, after combining and forming a complex, they are attacking the platelets. So if we see, if we try to find out, or if we try to measure the antiplatelet antibodies in acute ITP, we may not find anything. Okay, so that is actually non-specific. But in chronic ITP, that may be present and high. Now combining these features, because you see, the diagnosis comes after combination of all these features, like mucocutaneous bleedings, no abnormality in physical examination. At times there may be no examination of physical examination. Why it is like this? Because in case of chronic ITP, at times the patient may appear normal. Okay, but at times you will definitely, when the person comes with exacerbation stage, or in case of acute ITP, there will be bleeding spots. That is, these purpuric spots will be present. Purpuric spots, ecchymotic spots, they will be present. Okay, so you have to, this thing which is written here means that the person, if even if the person comes during the normal phase, that is, we have told the waxing and waning of the disease. So if the comes during waning of the disease, the patient may appear to be absolutely normal. Okay, and you have to note that the person is only having thrombocytopenia and no other abnormality in the CBC. That is, there may be anemia, but because there is bleeding, but the total WBC count should be normal. Okay, that is very important. Anemia may be present, because you see, if the bleeding keeps on happening over a longer duration, in case, especially in case of chronic ITP, so that may lead to anemia, but the WBC count should be absolutely normal. Bone marrow. Bone marrow shows increased or normal megakaryocytes. Okay, so that is very, very important. Platelets less in peripheral blood, bone marrow showing increased megakaryocyte, you have to term it as a ITP. Okay, so this is the, that's why bone marrow examination was placed before the coagulation profile, but coagulation profile is easier to perform, because for bone marrow examination you have to take the patient to a particular place and in a particular setting and then do it, because it is an invasive procedure, it carries some risk also. So that is why, and expertise also. So not everybody can perform a bone marrow examination. Unless a person is trained, he or she cannot perform bone marrow examination. I mean, bone marrow, uh, they cannot aspirate. That is, there are two methods: bone marrow aspiration and bone marrow refined biopsy. So that needs expertise. The differences between the acute and chronic ITP: one is the childhood disease, one is the young adults. One happens in equal numbers in both the sexes. One in one, we have more females and male than the males. History of preceding infection or vaccination is common in case of ITP. This acute, we have discussed all these points. I am just repeating and showing it in a tabular form for a better to memory. Okay, degree of thrombocytopenia: acute has severe, second one is moderate. Duration is self-limited, less duration, that is 2 to 6 months, and it may be many years. More than 1 year makes it chronic, and the disease may persist for many years. And prognosis of acute is actually very good, excellent in fact, and chronic ITP not so good, because it keeps on lingering, going on, coming back, going on, coming back, and steroid treatment may be needed. So we have to differentiate. We have to find out what is the. Then we have to find out what is the true cause of thrombocytopenia. Now we have, there are other causes of thrombocytopenia also. Before, after the acute and chronic thrombocytopenia, we have to see there are some other causes of thrombocytopenia also. So what can be the causes of thrombocytopenia? So there can be secondary causes of ITP like HIV infection, HCV infection, etc. There can be drug induced, there can be inherited. So we have to find out and eventually home on to the diagnosis of thrombocytopenia before terming it as a ITP, because ITP is immune mediated and most of the times we actually do not have a proper cause associated. That's why initially it was known as idiopathic, means the cause is unknown. Okay, so idiopathic word was used initially. Now also it is the true cause is not elicited in many patients, but even then, combining all the features, we term it as ITP. And the thrombocytopenia, which is associated with other hematological abnormalities, which I was telling, that it should be isolated thrombocytopenia. There can be anemia, but there should not be megaloblastic anemia, because megaloblastic anemia itself leads to due to vitamin B12 and folic acid deficiency, leads to the reduction in number of the RBCs, not only RBCs, WBCs and platelets as well. There can be these hemolytic syndromes due to in preeclampsia. There can be hypersplenism, malignant disorders like hematological malignancies, leukemias, and other conditions which need to be ruled out. That is the differential diagnosis. But most important is the ITP of all these things for the practical purpose as well as the examination point of view. Treatment is not part of pathology, but since we are in the new curriculum, we are supposed to practice this alignment as well as integration of these topics. So I have given a bit of this treatment in acute ITP does not require much treatment. It is mainly supportive treatment, and platelet transfusions may be required if the platelet levels go down to a very critical level, and at times, rarely, oral corticosteroids or immunoglobulin may be given. Chronic ITP is very difficult to treat, as I told you, because the disease follows a waxing and waning pattern, and steroids may be given, and in unresponsive cases IV immunoglobulin may be given, and in severe cases, though in some cases where the spleen is responsible and spleen becomes enlarged, though usually ITP cases do not show splenic enlargement, the splenectomy may be recommended, but usually not done. Okay. Sir, we have finished 1 hour. Should we continue or should we carry it over in the next class?
You can continue. If you have time, you can continue.
Sir, I have time. I don't have a problem.
No, you can
So,
continue.
okay, sir. So, coagulation disorders. Coagulation disorders are basically that they are different from the bleeding disorders because they are due to, mostly they are inherited, and they are due to some deficiency of the coagulation factors. We have discussed the coagulation pathway, and I am not going to discuss it anymore. So the coagulation factors, any of the coagulation factors, if they are deficient, may lead to the increased tendency towards bleeding, and that is the coagulation disorder. This is the picture from Robbins. We have discussed in our last class also, so I am not going to it anymore. Coming to the classification of coagulation disorders, we have this very important disease, that is the hemophilia A, which falls in the hemophilia A and B, which falls under the category of X-linked recessive disorders. The second category is autosomal recessive disorder. The third category is autosomal dominant disorders. We have some combined abnormalities, and last one is the miscellaneous category. So autosomal recessive disorder, we have hemophilia C. This term is not very old. So it was also known as Rosenthal syndrome. So that is due to factor 11 deficiency, and that is known as also hemophilia C. There is deficiency of prothrombin. There can be deficiency of factor 5, factor 7, factor 10. Deficiency of fibrinogen, which can be totally absent fibrinogen, or reduced production of fibrinogen, that is hypo. There can be factor 12 and factor 13 deficiency also. These are all under the heading of autosomal recessive disorder. Now, autosomal dominant disorder, most important is von Willebrand disease. Von Willebrand disease, when we discuss, we will see that there is a varying pattern. There can be autosomal dominant, there can be autosomal recessive also. So von Willebrand disease is by itself a very complex disease. And there may be dysfibrinogenemias due to functional deficiency of K dependent factors are 2, 7, 9 and 10. These are the four important coagulation factors whose synthesis is dependent on vitamin K. There can be some miscellaneous deficiencies like prekallikrein deficiency, high molecular weight kinagen deficiency, and there can be some physiologic inhibitors. So those physiologic inhibitors, not deficiency of that, actually they are the physiologic inhibitors. Those physiologic inhibitors, if they are there, so that may also lead to the coagulation disorder. Pathophysiology of the deficiencies of coagulation factors. Now, except fibrinogen and prothrombin, all the coagulation factors protein, actually a quantitative deficiency of this biosyn is that is delayed. The synthesis is both quantitative and qualitative deficiency of this one factor. If it is deficient, that okay. Hemophilia and von Willebrand disease may happen due to both qualitative and quantitative abnormalities of factor 8 related complex. Actually, factor 8 related complex is not only factor 8, it also comprises of factor von Willebrand factor. So that both together make the factor 8 complex. Hemophilia of the coagulation disorders, hemophilia is the prototype disorder and the most common disorder, and also from the examination point of view it is very important. In the bleeding disorders, ITP was very common and important, and here hemophilia is common and very important. Most common hereditary coagulation disorder, actually it is not the most common, it is common coagulation disorder, but the most common is actually now found to be von Willebrand's disease. Okay, so there is a mistake here. The term was first coined by Schonlin and originally termed hemerophilia, that is love for hemorrhages, but later on became hemophilia. And it is also known as royal disease because you see the royal families, they had a system of in their marriage between royal families only. So the recessive disorders, if it was prevalent in one family and two families, they kept on increasing. Okay, so the recessive factors, especially the recessive factors, they kept on spreading within these royal families. Not only this hemophilia, there are other diseases also. So since it was seen in Queen Victoria, who was a very important queen in the history of British Empire, and so Queen Victoria had a very long tenure as a queen, as this Queen Elizabeth too, who is also having who is also a queen for a very long time. So Queen Victoria also was queen for a very long time, and she suffered from. She was a carrier of hemophilia, not she suffered. She was a carrier of hemophilia, so that's why the it has been associated with the royal disease. It has been termed as a royal disease, and April 17th is celebrated as a hemophilia day. It should not be actually celebrated but observed, because it's not a cause of celebration. So it is actually the second most common of the inherited bleeding disorders. The commonest being one in 10,000, from 20,000 to 1 in 10,000 person, depending on the region where we are talking about, and occurs due to deficiency or abnormality of the factor VIII, which is as anti-hemophilic. Protein lacking or aberrant in hemophilia is, that is factor VIII, and the functional property of factor VIII is the known as the factor 8C. The functional property, remember, the property by which factor VIII functions, which is measured by the coagulation assays, is called factor 8C. And the antigenic property, which is measured by immunoassays, is called factor VIII antigen. So there is a difference between these two, this factor 8C and factor VIII antigen. So as we have already told you, it's X-linked recessive trait found in XQ228, that is the long arm of X chromosome. Disease manifests only in males because it's a recessive disorder, and it manifests only in males because males have X and Y, females have 2X. So it manifests in males mostly, while females are carriers. Okay, but we will see that females can also be affected when we will come to it shortly. So expressivity of the genetic defect varies from kindred to kindred, means it the from a particular family, in a particular family the genetic defect may be of a particular severity, whereas in another family the genetic defect may be more or less severe. So kindred to kindred means the family, one family to the other family, the genetic defect, the severity of the expression may differ. Okay. However, a positive family history may not be obtained in about 30% of the cases. Arises spontaneous mutation. That was Halden's hypothesis. And mutation rate for factor VIII gene is unusually high. It's quite high. Okay, so that's why spontaneous mutation of that X chromosome particular area, that is Y XQ228, that particular area, if it is affected, that leads to hemophilia, and spontaneous mutation may also be an important cause. And major inversion involving the intron 22 and intron 1 can lead to severe hemophilia, and point mutations lead to mild to moderate hemophilia. These are the genetic mechanisms, that's why I am telling you. So this question is asked in the Viva exam. Once you have diagnosed, also comes as a, in the problem based question, is a small question. how can hemophilia happen, or how can females suffer from hemophilia, not carriers. How can females suffer from hemophilia? Due to three important causes. One is due to lionization of the normal X chromosome during early embryogenesis. You see, though the females have two X chromosomes, one of them remains dormant and one of them is actually expressive. And that which one is dormant and which one is expressive is randomly selected. In all the cells of a particular female may not have similar expression of a particular X chromosome. Why? Because that is the basis. That is why females are called mosaics. Why? Because all the cells do not have the same expressivity of the X chromosome, because one X chromosome comes from the father and one X chromosome comes from the mother. So which X chromosome will be expressed or mother's X chromosome will be expressed is not known. It's like the dialogue in Sholay, कौन से खाने में गोली है किसी को नहीं मालूम. So which X chromosome will be expressed in which particular cell, nobody knows. So this lionization means the expressivity of the X chromosome in a particular cell. So if the normal chromosome is dormant, okay, if the normal chromosome or the X chromosome becomes dormant, is born, a female child is born from a hemophilic father and a hemophilic carrier mother, the child will have a homozygous gene. That is, both the X chromosomes are affected or having hemophilic gene. Okay, so then there is no chance of escape. So that's why the person, the baby or the girl will become hemophilic. Okay, hemizygosity means there is only one X chromosome and the other chromosome is missing. The other sex chromosome is missing. That is, in case of a example is Turner syndrome, where is we have only one X chromosome, one sex chromosome only. There is no Y, there is no X. Okay, so these are the conditions where female can have hemophilia, often asked in your Viva examination. Clinical features are variable and correlate with the factor VIII activity level. That is the factor VIII-C activity level. Normal level is between 50 to 150%. These are the types and what happens. I'm not going into details. Since I will be giving you the PDF, I will skip this. Manifestation. So the manifestations here are different. You see, this is pulpy or thrombocytopenia are different because they manifest as skin bleedings, skin spots, bleeding spots. Okay, mucocutaneous. The term is mucocutaneous. Muco means mucous membrane. Mucocutaneous bleeds are important for largely to the weight or stress bearing disease and often the disease I may have a bleed. So that is called aura. There is a feeling of that I may there's something bad is going to happen. So that is called aura. So often one specific joint is susceptible. Means left knee is more. There is a bleed in the left knee more. It's seen. So in a particular person. So that is specificity of a particular joint. Intramuscular hematomas, as I was telling you, the joints, the muscles, even the GI tract, the brain, they may be sites of hemorrhage. You see, the person, the child is having this swollen right knee. Okay. Okay, so that means there has been some intra-articular bleed. The joint space is filled up with blood. That's why it is swollen. Okay, since we know that the person is suffering from hemophilia, we can very well understand. But usually, if it is a fair-skinned person, there may be a bluish or blackish appearance. There may be, but since the person is a dark-skinned person from our country, so that difference is not very evident because both are looking almost same in color, and there is a loss of margins and landmarks. This is basically the swollen knee joint which is seen here. X-ray shows narrowing of the joint space due to erosions after multiple bleeds. The once the bleeding has happened, the blood after some time becomes resolved by the degradation of the RBCs and resorption, and the blood is taken away from the through the lymphatics. Okay, so gradually there is the swelling becomes normal, but repeated the bleeds lead to the narrowing of the joint space due to erosions. Okay, and the margins of the bone become sclerosed, osteoporotic, that is calcium becomes less in those areas, and a widened intracondylar notch and cyst formation may also happen. So the difference between the platelet bleed and the blood bleeding due to coagulation disorder. This is what I was telling you, the ecchymotic spot, wide areas of blackish skin bleeds. Okay, the small ones are the petechiae and the large one are the petechiae or the purpura. This large one are the ecchymotic spots, ecchymosis. Okay, and this is a typical hemarthrosis, means bleeding in the joint, that is the knee joint. So this person, the child, there is a bleeding in the left knee. Okay, lab diagnosis, everywhere we have to diagnose a disease, and our laboratory medicine or pathology, where here we have to diagnose a particular disease. Our main aim here is to diagnose a particular disease, and here also you start with the clinical history, that is the patient's history. Does the patient has a history of fall? The patient has a history of recurrent bleeds. The patient has a family history. You start with the history first, and very important. Second, you come to the physical examination, superficial bleed or a joint bleed. Then you come to lab investigation proper. We do the platelet count. In here, the platelet count is usually normal because it is not a thrombocytopenia. It is due to some coagulation factor deficiency. Bleeding time is also normal because bleeding time is mostly related to the platelet count. Okay, then we do the test for specific coagulation factors. So we have the two pathways. One is extrinsic pathway starting with the factor 7. We have the common pathway starting with factor 12. So those the intrinsic pathway and the common pathway, the test for those are increased because the intrinsic pathway is involved, because the factor 8 is from in the intrinsic pathway. Do you want to go back? Here we see the factor 8 is here. Okay, so factor 8, after factor 8 comes the common pathway. Okay, so factor 8 is in the intrinsic pathway, and factor extrinsic pathway mostly factor 7 and tissue factor, that is thromboplastin. Clotting time, crude test maybe is prolonged. Thromboplastin generation test points towards the plasma defect, that is plasma factor, coagulation factor defect. Factor 8 assay, that is the most important test to diagnose hemophilia. Before that, we can think that it is due to coagulation factor deficiency, but just telling that it is a coagulation factor deficiency will not be sufficient, because unless we can pinpoint the particular factor, it cannot be, we cannot treat the person, because we have to supplement this particular deficient factor. So initially we used to do mix and match studies. So mix and match studies means we take a deficient plasma, that is we used to mix with the normal plasma of a person, and then if the particular test, that is the APTT, becomes normal, we used to think a particular factor is deficient. So we can definitely we have these assays, one stage assay, two stage assay, micro methods, so by which we can diagnose the factor 8C, that is the factor responsible for the functional factor 8. Okay, that is acid, and we can also do it by a immunologic method, that is factor 8 antigen assay by ELISA or chemiluminescence assay. Therapy, in pathology we do not need treatment, but just for your basic understanding, we can give factor 8 concentrate or cryoprecipitate which contains factor 8C, 1 milligram factor and fibrinogen, and in some cases we can use injection desmopressin, which can basically we have to see the factor 8 level. So factor 8 C assay is important, and normal level of factor 8 C is which I have told is about 50 to 150%, but in carriers the level is expected to be half that of normal, and there is a ratio of factor 8 C to 1 milligram factor, the antigen. Their normal ratio is 0.74 to 2.2, but in obligatory carriers the value lies between 0.8. So these mathematical figures, so you have to know what are the tests. So factor 8 and factor 8 C assay and ratio of factor 8 C to 1 milligram factor, we have to find out. The genotypic methods, expensive methods, because here we use the molecular diagnostic tests. So restriction endonuclease analysis, oligonucleotide probe analysis, and RFLP techniques, these are important but very expensive, may not be possible in most of the labs. Prenatal diagnosis, because you see, if a person that the father is suffering from thalassemia, a mother is a carrier or mother is a normal lady, or vice versa, mother is a carrier, the father is normal, then uh, we do not want a diseased offspring, isn't it? So if we can have an option of terminating the pregnancy before the child is born, so we use those techniques, because the child should not be a diseased child. That's why the termination of pregnancy is carried out if we can prenatally diagnose the disease. It can be done by fetal blood sampling. It can be done by amniocentesis, meaning the this amniotic fluid is taken with the help of a syringe, and that is analyzed. And chorionic villus sampling, which is a very risky procedure, which can be done in early stage, that is 9 to 12 weeks, and that these from these samples may be taken, and we can do the genetic test to confirm that the person, the newborn is going to have a disease or not. Okay, did the newborn is the fetus is having the disease or not the newborn, because the child is not born yet. So the fetus is having the disease or not, that can be diagnosed from these. These are the sampling methods, these are not the tests, these are the samples. The tests are the this genotypic test. That is this PCR. The PCR is not mentioned yet, so PCR is very important. So we can in fact do it by PCR technique. It is written here also. So here also the PCR method can be used, and the one of the newer modalities of finding out without disturbing the fetus as such is from the DNA extracted from the fetal cells, that is lymphocytes and erythroblasts, which are present in the maternal circulation during pregnancy. From the maternal circulation, without disturbing the without disturbing the fetus, we can just take the blood from the mother and and extract the fetal cells which are circulating in the mother's blood, and we can analyze those cells by using the PCR technique. But this is not very well established method still now, and it is in an investigational stage. Hemophilia B, also due to the deficiency of factor 9, also known as Christmas factor, is also an X-linked recessive disorder, and the it is not so common as hemophilia A, and there is rate of spontaneous mutation is low, rather low. Lab diagnosis, here also lab diagnosis is almost similar, not severe, similar, but here by the factor assay we will see the factor 9 deficiency instead of factor 8 deficiency, but rest are normal, rest are same as this hemophilia A. Okay, here also we will have increased APTT but normal bleeding time and prothrombin time, and thromboplastin generation will show a serum defect. Okay, so factor, and this is not fixed assay, but actually this is factor 9 assay. So there's a one stage to assay, same almost same thing. Therapy is similar, that is you have to supplement the person with factor 9 concentrate. Carrier detection is also same as hemophilia. So the prototype disease of this particular category is hemophilia A, and if you remember hemophilia A, you can definitely write hemophilia B if it at all comes in your examination. Von Willebrand disease. I think this is the last disease, though this is a very large chapter, but I will be discussing this disease in bits and pieces, not go into very much details. This is more of a postgraduate disease because it comprises of various genetic manifestations. So most important bleeding disorder, most common bleeding disorder, not most important, but it is most common bleeding disorder and affects 1% of the human population. So you can understand 1% means a large number, and may occur due to both qualitative and quantitative defect of the von Willebrand factor, and it is a dominant disorder, autosomal dominant disorder with variable penetrance and expressivity. It is this particular thing which makes it as a tricky thing, because though it's an autosomal dominant disorder, at times it is expressed vehemently or very much, and at times it may not be expressed at all. So that is the meaning of the term variable penetrance and expressivity. Gene is located on chromosome 12. Okay, and it encodes the synthesis of the von Willebrand macromolecule. So von Willebrand disease, the macromolecule has various protein domains, A1 domain, A3 domain, C1 domain, D and D3 domains. So the normal concentration is 10 microgram per milliliter, and the circulating half-life is about 8 to 12 hours. Synthesis and storage, synthesized in endothelial cells and megakaryocytes, and it forms multimers. That is the major important thing, is that it never is a single entity. It forms multimers and stays together, and longest multimers or largest multimers are most efficient for supporting the platelet adhesion, because von Willebrand factor's main role is to for the formation of primary platelet plug. Okay, primary platelet plug, and also it acts with the factor 8 also, and helps in the coagulation pathway as well. But most important function is to support platelet adhesion. Okay, and it is also degraded by this ADAMTS13 after its action is over. With the interaction with GP1B on platelets, the antigen GP, glycoprotein 1B on the platelets, it helps the platelet adhesion. Okay, that I have told you, and also it protects the factor 8. It protects factor 8 from the this protein C mediated degradation. So as I was telling you, so it is a part of factor 8 related antigen complex, and it helps or protects factor 8 also. This is the picture from Robbins. I am not going into details. You see basically the factor, this 2B, 3A, 1B, they are all important for the platelet adhesion with the this von Willebrand factor. You see, this is a macromolecule, multiple small molecules together forming this macromolecule of von Willebrand factor, which helps in the adhesion and aggregation of platelets with the endothelial wall. This is the vascular endothelium. These are the endothelial cells, and it helps in the adhesion of the this platelet with the von Willebrand factor. This is the von Willebrand factor shown individually. Okay. Clinical factors, clinical features: disordered primary as well as secondary hemostasis. Mostly primary hemostasis, because it helps the platelet aggregation and adhesion. And in mild deficiencies, primary manifestations are the mucocutaneous bleeding, and in severe deficiencies where the factor 8 levels become also low, because factor 8 loses its protection from the by von Willebrand factor, which helps in the protection of the helps in the protection, which not helps, which also protects the factor 8 from the protein C mediated degradation, and leads to the factor 8 deficiency as well. In those cases, there may be hematosis, intramuscular hematomas, and lab diagnosis. The results have various, there may be variables, because it has been seen that patients with blood group O have lower levels of von Willebrand factors. Pregnancy, older age, and exercise increase level of von Willebrand factor, and it is heterogeneous nature of this disorder because of this variable penetrance and expressivity. Okay, so the parameters studied are bleeding time, APTT, factor 8 related antigen, this factor 8 C and factor 8 von Willebrand antigen, and this ratio correlates with the von Willebrand antigen levels. Okay, von Willebrand factor is to CB levels. So there is restrostatin cofactor activity, so which is a quantitative test for estimating the ability of von Willebrand factor to bind the target platelet. So this particular cofactor activity is important because it sees the ability of the VWF to bind the target platelets, and mainly affected by loss of large molecular weight multimers. If the large molecular weight multimers are absent, so this cofactor activity becomes low. Okay, and restrostatin induced platelet aggregation (REPA test). This is a qualitative test evaluating the rate of agglutination of platelet-rich plasma with addition of restrostatin. So this restrostatin, once it is there, this qualitative this agglutination of platelet-rich plasma, if you give restrostatin, whether it is inducing the platelet aggregation or not, it is noted. Okay. And we can also multimeric, we can also analyze the von Willebrand factor directly by assess multimeric analysis and genetic testing, of course, which is expensive by PCR based methods. Types of von Willebrand disease, I am not going to details of it, but this one is most frequent type is the type 1, which is autosomal dominant. Type 2 is also 2A is also autosomal dominant. Since I am going to provide you with the PDFs, I am not going to details. Type 2B is also dominant. Type 3, you see, this is autosomal recessive. That's why I was telling you not all forms are autosomal dominant. Type 2M, autosomal dominant. 2N, Normandy or autosomal hemophilia known as. So it is autosomal recessive type characterized by decreased ability of von Willebrand factor to bind the factor 8, the factor 8. Okay. This one is also autosomal recessive, but it is rare. Platelet type, that is also known as pseudo von Willebrand disease, which is again autosomal dominant. There are some conditions which lead to acquired von Willebrand disease. That is, the von Willebrand factor becomes abnormally low or less functional due to some other causes. This is also known as secondary causes, which is like hypothyroidism, autoimmune diseases, lymphoproliferative disorders like chronic lymphocytic leukemias or non-Hodgkin lymphomas, congenital heart disease, Wilms tumor, myeloproliferative disorders, and some monoclonal gammopathies. Treatment, we only give some agents like tranexamic acid, which actually stop the bleeding episode, or aminocapric acid, basically to stop the bleeding episode. And in severe bleeding, we also give desmopressin, which increases the level of factor 8 complex by release of this factor 8 complex from the endothelial cells, or increase production of by endothelial cells. And desmopressin is used in the choice of type 1 only. Okay. So this is the last slide of today. That is the difference between coagulation disorder and platelet or vascular disorder. At times it is asked in the Viva examination. So coagulation disorders are actually seen most commonly in males because they are the X-linked disorders, thinking of the hemophilia as the prototype. Platelet and vascular disorders are mostly seen in females. You remember the ITPs, chronic ITPs, mostly seen in females. Family history, often positive, often negative. Petechiae and bleeding, gums, nosebleeds, rare, here common. Deep hematomas, common here and not seen here. And delayed bleeding, recurrent bleeding after hours or days after injury is characteristic in coagulation disorder, that is hemophilia, and rare in case of vascular disorders. So the same thing which I have discussed today. So you please go back, have a look at this PDF. This PDF will be circulated to you, and do study on your own. If you have any doubts or clarifications, you can come back to me, write it in the group, and I will be happy to answer. Thank you so much.
Thank you, Dr. Palash. Extensive lecture must be very tiring for you. Very nicely done. And I think the entire bleeding disorder and coagulation issues have been covered. Thank you.
Yes. Yes.
Thank you.
Thank you, sir.
I'm going to record this.